Good afternoon and thanks for joining us. My name is Hazem El-Momani, consultant bariatric surgeon based in Abu Dhabi, the United Arab Emirates. It's a great pleasure to welcome you to this quite interesting session talking about how we deal with patients undergoing or being considered for bariatric surgery who have developed all sorts of complications related to their metabolic disorder. It's quite a mixed bag. We've got bariatricians, we've got surgeons, we've got intensivists, we've got cardiologists working or talking with us today. So I pass on the mic to my two moderators to introduce themselves and we can start the session. When you're ready for your questions, please reach for the mic, introduce yourself and fire.
All right, wonderful. Good afternoon. I'm Jamie Ard. I am professor of Epidemiology and Prevention at Wake Forest University School of Medicine in North Carolina, U.S.
Paul Burton, surgeon from Melbourne.
And I am going to introduce our first speaker, Dr. Mike Margison. He is an intensive care physician and bariatric anesthesiast who trained in Oxford, London, Sydney, and Munich. He is a founding member of both the UK and European Obesity Anesthesia Societies and has particular interest in education and the key issues anesthesia studies. Excuse me. He's moved back to Australia recently and
last week
gave a great talk in the pre-conference yesterday, so interested in understanding more about anesthesia and perioperative considerations in severe cardiopulmonary disease.
Thanks very much for the invitation to speak, and thank you for the introduction. It is going to be a bit of a potpourri, I think, these next 4 sessions. I'm going to talk about various bits and pieces, but really I'm coming from an anaesthetic perspective and talking about the high-risk perioperative management of morbidly obese patients undergoing bariatric surgery. And we see it not just in bariatric surgery, but we see it in all areas nowadays, gynecology, orthopedics. We just have lots and lots of big patients out there. And it's interesting to sort of first of all focus into where the comorbidity and the real disease is. So I'm going to show you a little bit of data on that at the beginning, talk a bit about ASA status and obesity. We all talk about the ASA grading the whole time. Let's just delve into it a little bit more for you. Talk a bit about the key comorbidities as far as I'm concerned, the cardiovascular aspects, a bit about perioperative considerations, and then hinting back to what we talked about yesterday in the pre-congress sessions, the red flags and the investigations that we will sometimes want in our patients who we think are at high risk. So this talk, it covers quite a lot, but I really want to focus in on this bit about exercise tolerance, the obesity-related pathophysiological sort of cardiac dysfunctions, a little bit on exercise testing. I'm just going to mention, I've actually taken the slides out on GLP-1 agonists because it could take too long, but there's an interesting question as to whether or any patient should be going forward today who's got significant heart disease who's not been tried on GLP agonists because they do so much all there. And then a final talk on risk benefits, which I think is probably one of the most important parts, knowing when to say no, who is really going to benefit, and more importantly, who is less likely to benefit. So, factors that contribute to outcome and bad outcomes are going to be preoperative factors, i.e. ASA status, high ASA status, so comorbidities, and then of course the intraoperative factors. So, question a little bit about is what of these are modifiable, and we'll come back to that in a minute. The first thing to say is about ASA status. It goes back, 1962 this was described, and it's really supposed to be a shorthand for us to tell each other about whether we think someone's not too much of a worry or is a real worry. It is a bit subjective to say, and you all know the sort of the statuses that are given. Forget ASA 5 and 6, those came later. The real issue, we all know about ASA 1s and 2s, and I can tell you in bariatric surgery, ASA 1s and 2s have almost no mortality or significant morbidities today. I'll show you some data on that. ASA 4 is a real, you've got to be really ropey to be an ASA 4, and you've got this great big thing, ASA 3, which covers a really broad church from one end to the other. And a lot of patients get labelled ASA 3, and it's sometimes a bit difficult to work out exactly what's going on. And if you are familiar with the ASA status, it changed around about 2014, 2015. The American Society decreed that anybody with a BMI of above 30 or 40 becomes an ASA 2 or 3 automatically, which is a rubbish for us in bariatric surgery because you lose the discriminatory value of having ASA 2s and 1s in amongst there. We have ASA 1 patients with BMIs over 70 who are fit young 23-year-olds who will swim 50, 60 lengths in the pool, but they actually are short and have a BMI of 70. So from our UK bariatric data back where I work, over this long period of time, we've looked at a whole bunch of patients, and I'll just show you some data on what the distribution of ASA status is amongst a bariatric surgical population. Note all these patients both underwent screening beforehand, so they're a sort of not a completely typical audience, and the death figure there is a 30-day mortality. Anyone who comes from ITU world will talk about 30-day, 90-day, 6-month and 1-year mortalities. And of those deaths that are listed, it's a large number, but the majority of these are post-discharge. So if you look at the distribution of ASAs amongst a bariatric surgical population, you can see that more than 50% of them, in our experience, are basically fit and well. And these are the younger ladies, and we all know this. But then you've got these other higher groups, this ASA4 is very clear, and these are the mortalities for each of these groups. And an ASA3 plus is something that one of my colleagues coined back in the UK about 15 years ago. And it's basically a patient who's not really ASA4, but who's got such significant cardiac disease that they can't climb a flight of stairs and they can't lie flat. And those are two key questions when we're looking at patients beforehand and asking and trying to ascertain whether they are okay or whether they are really ropey. Technical terms. Okay, so, pointer. If you look at that distribution by weight and by BMI, you see this kind of picture. The ranges, I hope, come up reasonably. And you could pretty much put the same weights on the bottom. It would be sort of weights above 180 kilograms would be that final group. But when you look at that, you can see in this population, get the clicker to work. Right. Oh, damn, did this earlier. Right, mouse. Well, basically, you can see where the mortality is. It's high up, and when you look at the BMI 70s, it's this group of the blue on the right. This is BMI 70 and above. All of that mortality is in the ASA 3 pluses and 4s. The ASA 3 was a 28-day COVID death that unfortunately just gets grouped in because that's what our endpoint was, died within 30 days. But it's all ASA 3 pluses and 4s. That's where your mortality is. And these are the patients who've got really ropey hearts. So first of all, I'd suggest, as a result of that, if you are talking to patients, kind of ignore the new BMI when assessing the ASA status. Got to get back to this. Or else 85% of your patients will get classified as ASA in a bariatric surgical service. And we tell our patients that the risk if you're ASA 1 and 2 is really low, and if they're ASA 3, we'd say, about 300, 1 in 300. And if they're an ASA 3 plus or a 4, your risk is going up to the 1 in 20, 1 in 50 range. And when you've got ropey patients, you've kind of got to give them a specific, customised mortality. Telling everybody that you've got a mortality of 1 in 500 or 1 in 1,000 is not right. It's not specific. Okay, patient pathways, we all know about these. We were talking this morning about day case surgery here, and it's fairly obvious that the higher the acuity, the more expensive it is. The better it is if you can get these patients through quickly, and enhanced recovery should be something we use for everybody, but fast track, where you're really trying to get them out of the hospital, is something we should be reserving a little bit for others. When you look at pre-op risk factors, and I showed this yesterday in the pre-congress course, if you look ASA 1 to 3 versus ASA 3 plus or 4, there's a 20 plus fold difference in mortality if you are in that high group. And if your BMI is over 70 versus under 50, this is not a binary. There's a group in the middle there who we've missed out. But again, you've got a much higher relative mortality risk if you have a BMI that's over 70 versus under 50. And funnily enough, exactly the same with weights, under 150 kilograms versus over 200, 16-fold. So these are pointing out the real risk factors for these groups. Age, interestingly, again, remember these are patients who've been selected and got through. Not statistically significant in our series, but what is very significant in every series that you come across is gender. Male gender, or male sex, I should say, is a very, very high risk factor in these patients. But again, the caveat with all of this, these are red flags pointing out the things to watch out for. The caveat is this was a group of patients who'd come through an MDT and been properly pre-assessed, and we'd already cut out some of the high risk customers. And those things are there in the OSMRS score, which you're all familiar with. And I think to this day, it's still probably the best tool that we use in our preoperative clinic. We talk about CPET testing, and that's a great thing to do. But the reality is you can't put a patient, the theory of CPET's great, but when you get one of these big fellas, you just can't really get them on the machines and work it out. And the best group in the UK who've done the most work on CPET testing is a group in York in the north of the country. And they actually specifically looked at a bariatric population, and they found that there was absolutely no benefit in CPET testing over simple OSMRS scoring when risk stratifying these patients. And that's been reported in other groups as well. So we've got a group of patients who have a spectrum of risk, and the one thing that's not in any of those previous pointers is shape, because visceral adiposity, you all know that, we know this, visceral adiposity is what gives you this pro-inflammatory, pro-thrombotic condition, and that's an additional risk factor, and that's involved in the development to a degree of cardiac dysfunction. So those patients with the tight abdomens, not just are you and I going to be having a battle, you're trying to insufflate an abdomen in this chap on the left, who's got it tight as a drum. I'm trying to push the diaphragm down to stop the lungs from collapsing. You're trying to push it up to give yourself more workspace. And we have this terrible battle in the guys who haven't had decent preoperative fasting to shrink their livers a little bit. The guys on the right with this sort of floppy tummy, they're going to be easier all round. And the other risk factor, which you don't think, well, you think about it, but anaesthetists and intensivists don't, is the patient with that tight abdomen is the one who's going to have the complications. That's where the diathermy burn is going to happen that doesn't get noticed, where the leak appears at a later stage, and it's the second hit, time and time again, we talked about this in an earlier session today, that leads to patients ending up on ITUs and doing badly. Sorry, let's get that right. Got it. So, we talked about the things that make for risks. And risks mean different things to different people. And for me, it's this one. It's cardiac risk. And this is where the rest of the talk is going to go, or the rest of the session is going to go. It is cardiac. And it is cardiac decompensation. It's the patients who've already got a degree of cardiac disease who then fall off their perches around the time of the anaesthesia, at induction, or at a later stage when they get complication. And it's the heart, and I'm not going to spend any real time talking about that. We know about this inflammatory milieu associated with visceral adiposity that leads to all these changes, and we kind of know the sort of things that happen to the heart. The second impact is the obstructive sleep apnea, and particularly the obesity hyperventilation syndrome patients. As the heart dilates up, they're at greater risk of dysrhythmias, atrial fibrillation primarily, and the heart. These guys have got an increased baseline cardiac output. They will have a larger stroke volume usually, and sometimes they're a bit tachycardic, sometimes they aren't, but their baseline cardiac output is increased, but they cannot particularly increase it further. They're pretty much fixed cardiac output states. So that's well recognised as a problem. There's a couple of recent studies that have come out there. Well, this one's from the European Heart Journal, and it was a few years old, looking at the relative increased likelihood, the odds ratio per increased 1 BMI point of all these diseases. I'm quite amazed that aortic stenosis is out there, and there's a cardiologist here, and I'll be fascinated to hear if this is your experience as well, that you see more aortic stenosis in obese patients. I'm not sure how that got there, but heart failure and atrial fibrillation, absolutely, these are the things that you see with a greater degree with these larger patients. And it's a heart failure with diastolic dysfunction, with this preserved ejection fraction, that seems to be more of an issue, at least according to the literature. I mentioned sleep disorder breathing. There's a whole group of diseases there. The obstructive sleep apnea component, which overlaps into this progressive obesity hyperventilation, where they retain CO2 high during the daytime. They're chronically hypoxemic. You'll remember those are the things that affect the pulmonary vasculature, and if you have high CO2s and low PO2s permanently, you end up getting pulmonary vasoconstriction, putting strains on the right heart, and then you get this combined right and left-sided heart dysfunction, which is certainly a contributor. And by correcting, identifying and correcting significant obstructive sleep disorder breathing and hyperventilation, you will improve these patients to a degree. How much of a degree is another question. So I've already mentioned this, and the second thing to remember about these patients with obesity hyperventilation OSA is a propensity to be sensitive, particularly to the residual opioids and other anesthetic agents. And these guys, obesity hyperventilation syndrome patients, who will have a high bicarbonate, a low baseline PO2 and a high baseline CO2, are the ones who have the respiratory arrests on the first night if they're given intravenous opioids and they're in the wrong place. And of course, they've got shoddy hearts. So when they collapse and crash, you're going to have a nightmare getting them back again. So, one of the indications to come to ITU, HDU, if you're going to need IV opioids, if they're well controlled, compliant with their CPAP, usually they're okay. And if they don't get intravenous opioids, usually they're okay. 2 usuallys. Okay, and the other thing about the sleep apnea group and the obesity hyperventilation group for the anaesthetists is almost by definition they'll have difficult airways and therefore a propensity to collapse the upper airways. So you don't need a lot of opioid and a lot of residual stuff to mess things up. Okay, so we've already said it's cardiac and it's cardiac decompensation. And I always tell my colleagues when I'm teaching them, assume in a patient who's got a limited exercise tolerance that they're going to have poor right and left ventricular function. And it's that exercise tolerance that's key. I'll come on to that in the next couple of slides. Assume they've got pulmonary hypertension. And if you're doing an anaesthetic on these guys, don't trust a non-invasive blood pressure, because if they flip into fast AF, it will not pick up a decent signal. You won't know where you're going. You don't know if the blood pressure's down at 40 or 50, or if it's up at 110 and you're actually okay. Arterial lines in these patients, these are the ones where you're going to have to wait whilst the guy sticks the art line in to make sure that they've got safe, continuous observation of blood pressure and perfusion pressure. And you've got to be a little bit careful with these other things. So yeah, assume your non-invasive pressure won't work, and assume with these patients, this is the other thing I tell our guys, you're going to have to ventilate them hard. So, I got 36, okay. So expect them to drop their blood pressures. And big patients, these ropey patients, they're like old patients. They've got their heart has got an accelerated deterioration and accelerated aging. So what do we do in the last 3 slides? So when I'm looking at these patients beforehand, I'm asking them, are you breathless? How easily do you get breathless? Where do you sleep? Can you sleep flat? On your side is fine, but if you have to sleep up with 3 or 4 pillows or in a chair, huge red flag to me. I'm really worried about that. And ask them about their exercise tolerance. They've all got bad backs and bad knees. You all know this. They can't walk up a flight of stairs. Walk up a flight of stairs? No, I can't. Okay, the building's on fire. You've got to climb a flight of stairs. Can you do it? Actually, yes, I can get through the pain. I can do it. That's gold dust to us. You know you actually have got a reasonable heart if they are honest with you there. If they say, the building's on fire and I can't get up the stairs, you know you've got a really bad one there, and you send them off for investigation, and you ask your cardiologist very kindly to try and help you. Screen them. Stop bang is not very specific. What I'm really interested in is not whether they've got sleep apnea. What I'm interested in is whether they've got sleep apnea and obesity hyperventilation that's knocking off their cardiac reserve. That's what I'm on about. That's the concern. And if you want to know if they're tolerant and go with their CPAP, you ask that question, what would happen if I took your CPAP away? And if they say nothing, they're not using it. And if they say, I wouldn't let you, tick, that one's going to be all right, probably with Oromorph, yeah? But that's the key question. Those 2 key questions are really vital. Okay, echoes and ECGs, I'll leave others to talk about that. Sleep studies, yeah, sometimes you're looking at bloods. Sorry, I shot through there rather quickly. Bloods, you look for an elevated bicarbonate, look for renal dysfunction, okay, and look for very poorly controlled diabetes. They're just generic risk factors in this patient group. So here you are at the end, coming to this question, when you see them in the pre-assessment clinic, are they improvable? What's their risk? What's their benefit? If they're I said it yesterday, I'm slightly facetiously, little old lady who sits on the sofa all day long, doesn't do very much. She's eating 1,000 calories, 1,100 calories, 1,200 calories a day. Restrictive procedures aren't going to help her lose much weight and probably aren't going to achieve a great deal. But in the younger patients, you'll take on a higher risk customer because the potential benefit, I guess, is that much more. So that's what the MDT is about. That's what we want surgeons, physicians, endocrinologists, sleep physicians, dietitians, psychologists, all in there together in the MDT, helping make these decisions. So I'll finish here. We continue to push the boundaries of risk in all areas of anaesthesia, all areas of perioperative medicine. We're taking on older, bigger, and sicker patients. The key thing about doing it safely is to understand what the problems really are that matter and ask the right questions to tease out that 10% of really high-risk patients. So you focus your efforts on those. And as I said, looking for sleep disorder breathing and looking for limited exercise tolerance is absolutely key. Where appropriate, say no, and get your patient back home. Be careful and be safe. And I hope that gets you in the right ballpark. Thanks for your attention.
Okay, thank you very much. We'll save your questions, write them down. We'll invite all the speakers up at the end to do a panel discussion. All right, so next we'll invite Dr. Sarah Gutman to the podium. She's a cardiologist who practices advanced heart failure and transplantation at Alfred Hospital here. and is also head of cardiac MRI at Baker Heart and Diabetes Institute. Dr. Gudley.
Thanks so much. So my topic was specific to bariatric surgery in a cardiac transplant program, how, when and why. So I won't be talking about specific cardiovascular perioperative risk, but very happy to answer any questions in the discussion. And I'll bookend the talk with 2 cases, one at the beginning and one at the end. So the first case is Mr. LW. He was first referred to us in 2021, aged 40, during the COVID pandemic for consideration of advanced heart failure therapies. And that for us means he's being seen by a cardiologist at another institution. They've gotten to the end of what they can offer therapeutically, and they've sent him to the Alfred for consideration of a heart transplant or of a mechanical heart, usually an LVAD, which I'll talk about a little bit more later. At this time, his weight was 155.5 kilos with a BMI of 46.4. The etiology of his cardiomyopathy was non-ischemic. It was diagnosed back in 2016. His ejection fraction nadir was 30%, and it improved to about 39% with good medical therapy. He also had atrial fibrillation, hypertension and diabetes, and he was having more frequent admissions with heart failure, but more concerningly with malignant ventricular arrhythmia. He had a biventricular pacemaker and an implantable cardioverter defibrillator in situ, and he was getting recurrent shocks. And this culminated in an admission to ICU at the end of 22, where he required inotropic support. But unfortunately, a ceiling of care was given at that time because of his BMI. So we decided that we wouldn't put him on any temporary mechanical support, such as ECMO or impeller, because there was nowhere to go from there, as he wasn't a transplant candidate. He wasn't a candidate for an intracardiac ablation for ventricular or atrial arrhythmia due to his anaesthetic risk, and he was on the disability support pension. His wife is a nurse and they have 3 children. So he got through the ICU admission and a few other admissions, and after a period of engagement with our team on the ward and in the outpatient clinic, it was felt that he was a suitable candidate for advanced therapies. However, his weight was a major contraindication. And to highlight our usual multidisciplinary process at the Alfred, the first step is really that the heart failure team feel that we can engage with the patient, that we can work with them, and that there'd be a candidate for advanced therapies before we present that to the bariatric team. Then the patient will meet with our bariatric surgeons and the rest of the wider team and agree to all the pre and post-op commitments such as Optifast, etc. Then we do a right heart catheter, and I've got 2 here for your consideration. So Mr. LW at the top, sorry, that should be LW, who had this right heart cath at a weight of 159 and a BMI of 47.4. And the first thing we look at is really, are they well diuresed? Are they euvolemic? Because that's a really challenging assessment in this patient. Often we can't see their JVP. A lot of patients don't have peripheral edema. Echo and ultrasound is challenging, and even cardiac MRI can be challenging. So we really rely on the right heart catheter a lot, the first thing being their fluid status. So we can see the RA pressure is normal, the wedge pressure is normal. The cardiac index, as a sign of their cardiac output, is low. That's, of course, adjusted for their body surface area. But if you look at their cardiac output, unadjusted, 4.7 is not too bad. And then finally, of course, we look at their pulmonary pressures because that'll be important going into the operation. So Mr. LW's were normal, 31 on 18. And I've just included another patient that we did actually decline for bariatric surgery to compare and contrast. So this is Mr. AB, and he had a similar-ish BMI, 46.8, but you can see his cardiac output is much lower at 3.3, giving him an index of 1.3. He has pulmonary hypertension, severe pulmonary hypertension, with a PA systolic of 65 and a very bad hemodynamic profile with a normalish right atrial pressure, but a very elevated wedge pressure. So after the right heart catheter, we have a multidisciplinary meeting with the bariatric team and the cardiac anaesthetic team to really see if the cardiac anaesthetists are happy to go ahead with the gastroscopy. We use the gastroscopy as a test to see how the patient will tolerate the anaesthetic. And then if we feel that they've gotten through the gastroscopy quite well, we'll have another MDM and then include our intensive care team, as we'll routinely send these patients to intensive care after the surgery for a period of monitoring. So Mr. LW underwent lap sleeve gastrectomy on the 22nd of February this year, which was uncomplicated. He had a shortish stay in hospital and went home. And I've put here his last weight measured in clinic, that was at the beginning of August, was 126 with a BMI of 37.7. But I actually did see him in heart failure clinic this morning, and his BMI is now 34.2. And that is very important when I go to the next, when I talk in the next few slides about cardiac transplantation. So there's been a lot of reports and studies in the literature about the safety of bariatric surgery in patients with heart failure. I've included some data from this meta-analysis of 14 articles with 217 patients. And really a lot of the papers show that it is a safe procedure with the multidisciplinary team involvement for appropriate case selection. In terms of LVF improvement, the mean difference was only 7.8%. And the improvement in NYHA class was only a mean reduction of negative 0.4. And NYHA class, there are only 4 classes. So a negative 0.4 is really not clinically meaningful, especially in these type of patients. And in someone like Mr. LW, these changes won't be clinically meaningful. And also his main issue is really arrhythmia. So that's not going to improve that much. And this is really my main slide. So this is why we put all these patients through this rigorous MDM and have so many discussions about them, is to try and get them to transplant, because that's really the only treatment in a lot of these patients. And a BMI greater than or equal to 35 is considered a relative contraindication to heart transplant, and certainly in our centre it's an absolute contraindication. And this is because of data from the large ISHLT, so International Society of Heart and Lung Transplantation Registry, which looked at 38,500 patients between 2000 and 2014 greater than the age of 18. The majority were normal weight, overweight and obese class 1. And there was an increased mortality risk in class 1 obesity and class 2 obesity, but a huge jump in class 3 obesity. And that's where this cutoff has come from. And you can see really the drop in survival at that higher BMI. Obesity was associated with an increased risk of death secondary to myocardial infarction, chronic rejection, infection, and renal dysfunction. And this kind of retrospective study really led to a change in the guidelines back in 2016. So prior to that, in 2006, a BMI greater than 30 was really a relative contraindication, whereas in 2016, after this big registry publication, it moved up to 35. But in a lot of centres, and certainly in our centres, we really only relaxed our BMI criteria in the last couple of years because there was so much fear about getting through the transplant operation itself, the stay in ICU, managing immunosuppression with such different volumes of distribution, the risk of renal failure, etc. But bariatric surgery is a very effective intervention as a bridge to cardiac transplant, and I say that really as highlighted in the case. It's a bridge to cardiac transplant eligibility usually. This is quite a small study, but only 18 patients. But it did show that in 71% of patients who underwent bariatric surgery, they achieved the BMI target of less than 35 to allow them to become transplant candidates. And that's huge. There's nothing else that we can really do for patients who aren't eligible to make them eligible. We won't get 71% to stop smoking or drinking or drugs or improve their social situation. So it really is an effective treatment. 2 patients in this study did have an increase in their EF to normal limits. And as I said, that hasn't really been our experience, but certainly is in the literature. And a caution in these patients is that those who do go on to transplant spend more than the usual time outside the therapeutic immunosuppression range, but thankfully this hasn't translated to increased rates of rejection. The next part of my talk will focus on bariatric surgery in patients with left ventricular assist devices, LVADs. So these are electromechanical circulatory pumps for end-stage heart failure that are used as a bridge to transplantation. Now, in the US, there's a good destination LVAD program. So in older patients that you don't think will ever get to transplant, they could have an LVAD as a long-term therapy, but that's not on the MBS in Australia. It's a mechanical pump that's implanted in the patient's left ventricle, and it receives blood from the LV and then delivers it back to the aorta. And it consists of an implanted pump, a driveline that connects a pump to the controller, and an energy supply that the patient wears at all times. Now, the issue is that the driveline exits the lower chest and passes subcutaneously across the abdomen, exiting on the left or right, depending on the cardiothoracic surgeon preference. And already, this is US data, so they have much larger rates of obesity than we do, but already 29% of LVAD recipients had class 1 to 2 obesity at the time of device implantation. So there's certainly no contraindication to implant an LVAD as a bridge to weight loss, and therefore candidacy to transplantation. Patients are more prone to cardiac arrhythmias and less tolerant of exercise, and sometimes we say that it's not a bridge to transplant but a bridge to fridge, because the increased cardiac output allows them to get up and around more. So we do see a lot of weight gain on LVADs, and that's also why surgery is important in this population. This is a small study again, but I've just included it because it included some technical aspects, which I hadn't found in a lot of the other studies. But 7 patients with end-stage heart failure and LVAD in situ who underwent lap sleeve gastrectomy as a bridge to make them acceptable candidates. And they gave some tips about where to put the ports and highlighted the importance of avoiding injury to the driveline and the pump, which is kind of, as you can see, in your working space. So that's obviously an important consideration. They found that bariatric surgery was safe and feasible in this high-risk group. The median length of hospital stay wasn't too bad. There were some complications, including gastrointestinal bleeding. And remember, these patients are managed on warfarin routinely to avoid pump thrombosis, stroke, etc. But in the newer pumps, the HeartMate 3, which is now the only pump available in Australia, we found that our stroke rates are actually very low, and we're quite comfortable having patients off warfarin for periods for surgery or whatever type of intervention they need, unless there's another indication for warfarin. And there was no 30-day or 1-year mortality, and there was an effective weight loss outcome from 43 to 37 and a modest improvement in cardiac function overall. There's also been larger meta-analyses in this group, this one of 271 patients who underwent bariatric surgery after LVAD implantation from 11 studies. 67% were listed on the heart transplant list, which is massive. 32% underwent a successful transplant. The mean listing time was 13.8 months. And there were, complications, 47% for 30-day readmissions, 23% for 1-year mortality, and I said that wrong. Pooled complications 47%, 23% 30-day readmission, and mortality 10.2%. Cautions in this group are it needs to be appropriate case selection with the multidisciplinary team, so that advanced heart failure cardiologists need to be involved, the mechanical support coordinators, bariatric surgeons, cardiac anaesthetists and intensive care. There needs to be a robust anticoagulation management plan, and perhaps the involvement of cardiothoracic surgeons to avoid driveline injury. So my last case is Mr. DW. He first presented to the Alfred in 2013 as a 23-year-old man with a new diagnosis of dilated cardiomyopathy with a heart that didn't really move at all in cardiogenic shock. His ejection fraction was about 15 to 20%, and he was treated with IV furosemide, dobutamine, and levosimendan. He was obese at that time with a BMI of 34.2, carried most of it in his tummy, so you can't really see it there. And he also had a bicuspid aortic valve, which wasn't thought to be contributing to cardiomyopathy, depression, and obstructive sleep apnea. He was in our heart failure clinic from 2013 to 2017, very stable. But in 2017, he was admitted with decompensated heart failure, and it was noted in the notes that obesity was a significant contraindication to heart transplant. In 2020, he developed worsening heart failure and kidney injury and was referred to the bariatric clinic at that time. Before he could even be considered for bariatric surgery, he presented in cardiogenic shock and was worked up for an urgent LVAD, which was inserted in April 2020. He was well supported for 6 months, underwent transplant workup, as is our practice, and it was noted in the presentation for transplant that while he's suitable, he would need to lose a significant amount of weight prior to being listed. He'd need to have a target weight of 107 to achieve a BMI of less than 32. We've relaxed our BMI criteria since then. He will continue to work to the dietitian to this end, which he did, very, very closely with our dietitians. We've got excellent dietitians, and he was on Saxenda, but as you can see, he never even got close. I mean, when he had decompensation, he'd lose weight. The LVAD implant caused his weight to plummet, but then again, as I said, it can really go up on the LVAD, and he just really didn't have a chance. So in 2021, he was referred for consideration of bariatric surgery. He had a sleeve gastrectomy in February last year off warfarin. His pre-op weight was 151 with a BMI of 44.8. And in June 23, he achieved a BMI under 35 and was listed for heart transplant. He underwent a heart transplant in November last year. He did have some complications of primary graft dysfunction where the heart doesn't work initially, but he overcame that very well. And he had 1 episode of treated rejection. He's now 9 months post-transplant. He's well, his heart is normal, and he's 105 kilos. I just included one slide about future directions, which we have a new kind of newish cardiac pump, which is a form of temporary mechanical support that goes in through the aorta into the left ventricle, and we use it really for PCI, for supporting high-risk PCI, but there's been a few case reports in the literature about using this pump to support patients with end-stage cardiomyopathy through bariatric surgery, so that's something that we could think about. Thank you very much.
Thanks very much, Sarah. I think our next speaker is David Yeo, a surgeon from Sydney. I think David's well known to a lot of the audience. He's a upper GI and liver transplant surgeon, as well as an experienced bariatric surgeon. David's going to tell us particularly about MAFLD, cirrhosis, and bariatric interventions.
Thanks very much, Paul. G'day, everybody. So thanks very much for the organisers for the invitation to speak. So we're going to focus on MAFLD generally, and then I'm going to sort of talk more about cirrhosis and the involvement of transplant and how they intersect with bariatrics. I have no conflicts. Talk a little bit about the epidemiology and some of the nomenclature changes, and then a brief run through the treatment options available, and then cirrhosis and transplant. As everyone in this room would know, this is a big problem. About 1/4 to 1/3 of people in the world have fatty liver disease, and the incidence is increasing, and the significance of the incidence is increasing as well. Interestingly, 40% are not obese, but the cost is huge, about $100 billion US in the US alone. Importantly, there has been a nomenclature change in 2020 from non-alcoholic fatty liver disease to the metabolic dysfunction associated fatty liver disease. I use it simply because a lot of these slides will have the NAFLD rather than MAFLD, and really it's to have clear criteria to demonstrate independence from other liver diseases. So if you've got steatosis and you're overweight or obese, or you've got steatosis and you're diabetic, Either of those would be classified as MAFLD. Similarly, if you are lean or normal weight but have steatosis and 2 metabolic risk factors, then you qualify. There is, of course, a broad spectrum from a healthy liver, of which a quarter will have fatty liver disease, of which a quarter will have NASH, of which a quarter will have cirrhosis. So about that ends up in the population, meaning 1 to 2% of the population will have cirrhosis, 5 to 6% will have NASH, and 25% will have fatty liver disease. And remembering all of these categories can turn into HCC, which is why we have to be mindful of this. If we talk generally about the management of MAFLD, we're talking about really modifying the components of metabolic syndrome, the most important of which is obesity. But of course, type 2 diabetes management, insulin resistance, dyslipidemia and hypertension are important. It is generally considered, and there's some disagreement on this, but it's generally considered that the mainstay of treatment for MAFLD is weight loss of between 7 and 10%. And there's currently no FDA or in Australia TGA approved medication as treatment for it. When we are talking about the impact of these interventions, a lot of these studies talk about changes in histology. So remembering that fatty liver disease on the top left-hand corner will go down to NASH, which will turn into NASH with fibrosis and then to cirrhosis. And that is sometimes encapsulated in a score called the NAS score, which is essentially an unweighted score out of 8, which validates the measure of disease activity on liver biopsies. Now, it's not a diagnostic score, but it does correlate in terms of change, and that's very helpful when you're trying to work out whether an intervention is working or not. And finally, the fibrosis score of 0 to 4 in terms of changes in fibrosis. And these are important to remember because fibrosis is associated with NASH and is the main predictor of liver complications and M&M cardiovascularly. So if we're talking, this is about bariatric intervention in the context of MAFLD. So we've got all options available at the moment. We've got lifestyle modification, medications, endoscopic options and bariatric surgery. And of course, as we go up the vertical axis, we increase our efficacy, but as we go along the horizontal axis, we increase our risk. Let's start with lifestyle modification. So we've all been to the gym and we've all done diets and we all know that this is a challenging thing. And whether or not we agree with the fact, as they suggest in this study in 2017, that after 52 weeks of lifestyle modification, you can get steatosis improvement in 100% or fibrosis regression in 81%. The figure that I want you to look at is this one at the bottom right-hand corner. Only 10% of people on a lifestyle modification regime will actually get to the end and achieve a weight loss. This is the biggest problem, as we all know, and this is why we're all at this conference. Let's move up one rung to medications. Well, we actually have some very recent data that's been published in June this year in the NEDGM looking at the impact of tirzepatide against placebo in a randomised controlled trial looking at this very question of MAFLD. It was a randomised controlled trial, they looked over 52 weeks and they demonstrated that on various doses of this medication that you could achieve resolution of steatohepatitis with no worsening fibrosis in up to 62% of people. Now, this study was not powered to assess fibrosis, but it demonstrated resolution of MASH. What about endoscopic options? Well, we have a variety, and there are many more than I have a picture of on the left, but this systematic review looked at 18 studies and demonstrated that there was a mean difference of 0.7 in terms of liver fibrosis and definitely improvement in surrogates of fatty liver disease. Now, one of the problems in this whole area is the assessment of fatty liver disease is quite subjective. If anyone who does transplant and you get a biopsy of a donor, trying to get a consensus on how fatty a liver is incredibly difficult. There is a huge amount of intra-observer variability. And that is one of the challenges of these studies when you're looking at impact and change. Let's focus, however, mostly on surgery. One, because that's where most of our data exists, and two, we're obviously most interested in it here at this conference. So here's a Cochrane review looking at a huge number of patients and looking at the different histological changes in terms of MAFLD. We look at steatosis demonstrating 60 to 91% depending on which kind of study they reviewed, 50 to 91% change in inflammation, 75 to 77% of ballooning. Remember, that's one of the histological changes in NASH. And in terms of fibrosis, up to 40% of improvement. It's important to remember, though, there is a percentage of of people who actually get worsening in their liver fibrosis, up to 12% when they actually have weight loss and bariatric surgery. And it's thought to be related to rapidity of the weight loss, and it is more common in the malabsorptive procedures such as the small bowel bypass procedures. In terms of randomised evidence, there is not a lot around, but this is one of the few studies published in The Lancet last year which compared bypass to sleeve to lifestyle interventions in terms specifically looking at the impact on MAFLD. It was a randomised controlled trial, 1:1:1 over 12 months, and their endpoints were the histological resolution of NASH without fibrosis worsening in 1 year, and their secondary endpoint was fibrosis improvement by at least one stage on the fibrosis scale. As you can see on the right side of the screen, and these were statistically significant, that surgery was vastly better, 3.6 times more likely to achieve resolution as compared to lifestyle interventions. The threshold at which the endpoint was achieved was interestingly 20%, which was double what has been previously suggested at 7 to 10% to achieve this endpoint. And secondly, sleeve gastrectomy was equivalent to Roux-en-Y gastric bypass in terms of MAFLD. However, bypass was better at improving glycemic control, lipid profile, insulin resistance, and weight loss. So the question is, when we're looking at all of these different interventions, if you think back to that graph with our lifestyle interventions, medications, endoscopic options, and surgery, longevity is something which is the sort of elephant in the room. Any intervention in bariatrics which is reversible or short-term or temporary tends to follow this graph where there is initial improvement and then there is weight regain and change back to the preoperative or the pre-intervention state. This is the truth even in transplant. People who have transplants for NASH disease and have their transplant, about 80% of people will get recurrent fatty liver disease if their weight is not managed. In terms of bariatric surgery, it is one of the few interventions we have long-term data for, and at 5 years, generally speaking, the chance of having NASH prevalent at 5 years in the 99% of the 99 people who had NASH in this group, at 5 years, NASH prevalence was low, the severity of the steatosis ballooning and the NAS score was low, but what they demonstrated was that at 5 years, the changes were essentially the same as what they demonstrated at 1 year. So remembering that your improvement goes to 1 year, but as long as your intervention is persistent, then you will maintain that improvement. The fibrosis, interestingly, in some patients did worsen over the 4 years between 1 and 5. So we've got evidence that bariatric surgery works. We've got that evidence in many comorbidities, but specifically in MAFLD disease. The next question is, what operation is best? And generally speaking, as was demonstrated in that randomised controlled trial, there really, in terms of MAFLD outcomes, there is not a great deal of difference between a sleeve gastrectomy and Roux-en-Y gastric bypass, whether it be in terms of histological changes, the NAS score, or fibrosis. There's the data from our randomised controlled trial again. So I'm going to move on to the next section of cirrhosis. Obviously, cirrhosis can be caused by lots of things, but NASH cirrhosis is becoming increasingly common as fatty liver disease becomes a bigger problem. When we're talking about the intersection between bariatrics and cirrhosis, we're not so much talking about the impact, although there is, and I'll talk about that in a minute, but it's more about the safety. Can this person have a sleeve, for example, if they have cirrhosis? Well, there is definite evidence that if you have a sleeve or a bypass procedure in the context of cirrhosis, that you have increased morbidity up to 21% and increased both perioperative mortality of 1.6% and late onset up to 12 months mortality up to 2.8%. Most of these studies, however, half the people in them are diagnosed incidentally. So they're not people who have cirrhosis and then go to surgery. They have cirrhosis diagnosed at the time of their laparoscopy. The nationwide inpatient sample in the US has looked at extra risk factors, and if you have portal hypertension, in addition to your cirrhosis, even if you are Child's A, if you have a worse outcome. It also identified that if you have a non-restrictive operation, such as a bypass, that you do worse as compared to, say, a sleeve. Low volume centres, not surprisingly, have an increased morbidity and mortality. And of course, if you have decompensated cirrhosis, then your mortality is vastly higher at 16.3% versus the compensated group. They didn't talk a lot about why people with decompensated cirrhosis were having surgery. So the contraindications in the context of cirrhosis and a safety issue really are, if you have a Child's Pugh B or C patient, if their Child's Pugh score is over 7, essentially, or they have portal hypertension diagnosed endoscopically or radiologically or on hepatic venous wedge pressures, then they really shouldn't be having surgery. But if you can get them through the surgery, if you choose the right patient in these carefully selected patients, then they will do as well as non-cirrhotic patients. So here's a case control study looking at patients with Child's Pugh A cirrhosis, or 97% of the group had Child's Pugh A cirrhosis. Admittedly, half were diagnosed preoperatively, but their weight loss was equivalent over a combination of 3 years. The final section that I'd like to talk about, given that this is the extreme sort of X factor session, is how bariatrics and transplant intersect. NASH is an increasingly common reason for people to have liver transplant. If you compare 20 years ago, the number of people who had NASH causing them to have cirrhosis, causing them to need a transplant was very low. We're talking at 1 or 2%. And now we're talking up above 20%. Now, obviously in transplant, that's a multifactorial issue. Fatty liver disease and NASH cirrhosis is becoming more common, but also the number of people needing transplant is changing. The proportion of people needing transplant is changing. We have less people with hepatitis C, for example. So of the donors we have more of a greater proportion of those people having it for NASH cirrhosis. The difference, of course, is that transplant patients, when we're talking about obese transplant patients, they're very, very unwell. We're talking about people who are sarcopenic, coagulopathic, thrombocytopenic. They're not the best candidates for anything. So the question is, well, why would we be even considering bariatric surgery in this kind of sick, unwell population? Well, to start with, we know that obese patients waiting on a liver transplant waiting list do worse. They get more disease progression. They are more often overlooked in terms of organ distribution. We also know that after the liver transplant, assuming they maintain their morbidity, their obesity, because of their comorbidities, they have higher mortality after their liver transplant. And that's probably related to the fact that it's very hard doing a liver transplant in someone with a BMI of 45. It's a technically difficult operation made more difficult by their obesity. So why do people have surgery? Well, in some countries you can't get a liver transplant if your BMI is over 40, and so some people will be referred for a bariatric surgery prior to liver transplant to physically facilitate the surgery and to prevent recurrent disease, and I'll talk about that in a minute. There are therefore 3 times we could offer it: before it, during it, or after it. Let's look at the before group. Clearly, as I said, these people are going to be relatively unwell. They're going to be sarcopenic, they're going to have portal hypertension and other comorbidities commonly seen in anyone waiting for a liver transplant. But there are studies that have looked at it, and I am certain that this is a better group of people waiting for a liver transplant. If you look at someone who's got HCC as a result of cirrhosis, they're probably doing much better than someone who's got overwhelming sepsis and liver failure in ICU. So we're talking about the better people in this group. If you can choose the patients, you can essentially achieve no mortality and a reasonable morbidity of about 25%. Is it effective? Yes, it is. At 2 years, their weight loss is approximately 60%, and 85 to 90% of people who get it can therefore meet the criteria for getting a liver transplant. What about during the transplant? Most people, in fact, I would say, would not be able to have obesity surgery prior to their transplant, but a lot of people we know are coming to transplant with a lot of weight on board. Well, a retrospective cohort study looked at people who had a liver transplant with a combined, usually sleeve gastrectomy, versus the other people in their database, essentially everyone who had a liver transplant who had not had obesity surgery. And there was no difference in terms of safety, in terms of morbidity, mortality, or length of stay. It is definitely better if you are obese and you have a liver transplant and you are able to have a sleeve gastrectomy at the time of the liver transplant, because your chance of being able to minimise your weight, maintain about over 10% of your total body weight at 3 years, was 100% versus 29%. So that group who 29% essentially hadn't had bariatric surgery and had basically remained obese after the liver transplant. There is a huge percentage of people who have recurrent disease, as I said, 80%. The problem is, of course, that sometimes transplant looks more like an Al Pacino movie than it does a normal operation. And the last thing you want to do is to do a sleeve gastrectomy and manage a sleeve leak in someone who's immunosuppressed and obese. The sleeve is our choice if we do it. At the time of transplant, it's a shorter operation time. It's very important to maintain gastric continuity because after a liver transplant, patients sometimes need biliary interventions like an ERCP and stent. And we want to have predictable absorption for immunosuppression because obviously that's critical in terms of transplant patients. At RPA, we have a protocol whereby if patients have NASH cirrhosis and their BMI is over 40, they've had multiple attempts at weight loss, we send them to our metabolic clinic. And if they do go to surgery and they're consented, they get a sleeve gastrectomy, we will keep a nasojejunal tube in them for the 2 weeks after transplant. We've got this funny situation where we have to maintain them nutritionally as well as we can while they're recovering, but we therefore are able to move that afterwards. It is at the discretion of the surgeon, and we've only done 2 in the last few years. So it demonstrates that there's not a lot of enthusiasm for it, given that the transplant patients that we're doing are pretty sick. And finally, there's bariatric surgery after liver transplantation. There is definitely evidence to suggest that it's possible, but there is significant morbidity, up to 16% having major postoperative morbidity and 1.4% having mortality. And it's thought that this is related to people who are immunosuppressed, have lots of adhesions, and are still obese. So in summary, it is a big problem, it's widespread, it's increasing, and it is having a significant impact on mortality. Weight loss is the mainstay of treatment for MAFLD, and lifestyle modification, while useful, is only useful if it is achieved. Medication is showing promise, but the studies are short-term and early. Bariatric surgery can reduce and resolve these changes, although fibrosis can progress in 15%. We know that surgery is safe and effective in carefully chosen cirrhotics, but they must be child's A. It's equally safe between sleeve and bypass up to the level of NASH, but once you're getting to cirrhosis, we generally recommend a sleeve, and similarly in terms of transplant patients. Thank you.
Thanks very much, David. I'll invite our next speaker, Dr. Ian Michel. Ian's hopefully well known to many in the audience. He's a very experienced bariatric and also transplant surgeon. I think been involved in bariatrics since the 1990s, Ian, could that be right?
80s.
80s. Seen all the procedures. So Ian's going to tell us about renal disease and transplantation and the role of metabolic surgery.
What an interesting afternoon. Last talk, we're nearly there, folks. So Dr. Almani, Dr. Ard, Dr. Burton, colleagues, as you know, my name's Ian Michel. I'd like to start with expressing my respect for the Indigenous owners of this land, the Wurundjeri people and the Bunwurrung people of the Kulin Nation. And it's traditional to pay our respects to their elders past, present and emerging. So I'm a Melbourne surgeon. I'm approaching the end of my practicing life. In the past 19 years, I've had 2 distinct interests. I've been running a bariatric surgical practice, largely in the private sector in Melbourne, as we all do, aiming at performing low-risk operations such as sleeve gastrectomy, where the mortality is about 1 in 1,000. If we can offer this surgery to candidates before they develop diabetes, we can prevent complications like blindness, peripheral vascular disease, and end-stage renal failure. My other life has been the lead renal transplant surgeon in 3 sites across the city. As you know, we have the data. As you know, we've been less than successful at persuading our colleagues to refer pre-diabetic patients for effective, durable weight loss. So, obese type 2 diabetic patients reach renal failure and require renal replacement therapy and meet me, wearing a second hat. In this world of end-stage renal failure, it's high risk. The chance of a middle-aged person... Does this thing work? No, I can't get it. Oh, yeah, there we go. A middle-aged person has the chance of surviving 5 years is around 70%. The cost of haemodialysis in Australia is about $100,000 per year. In our country, we have universal health insurance that picks up the tab for this, but in other countries, this is an attack on the assets of not only the patient, but potentially the entire family. Any operation that can do better than that is a win, right? Renal transplantation has a mortality at 1 year of nearly 2%, but that's a whole lot better than dialysis. If you can find a living donor, the mortality rates are even less. Sadly, these results are not quite the same in the presence of obesity. In obesity, renal transplantation has a significant poorer outcomes. This paper from Gore in 2006 was based on UNIS data, registry data, and categorised 5 groups of patients according to their weight. But at that time, a lot of units in Australia, and I think the US as well, were excluding obese candidates from transplantation. So you can imagine the selection bias if you're using that same registry data to tell you the outcomes. 10 years later, this same source of data was used by Suresh Kumar in a matched analysis, turning the data around but finding the same results: more delayed graft function and graft loss in the obese. I think we're all familiar with the pictorial depictions of the obesity epidemic in the US and probably the pictorial depictions of obesity and globally. And this is how it looks in Australia. There's a continuing increase in the prevalence of obesity in our country too. Suresh Kumar demonstrated this in that study I mentioned, showing the flux of BMI over the time that the data was being collected. If you add to this the time between data collection to publishing, we really need to be careful about how we interpret what is found, because where we are now is different from then. This is, by 2015, the landscape is quite different again. The average transplant unit in the US has 1 in 8 patients with severe obesity. 11% of the units have 1 in 5 obese patients, and only 14% of units have low rates of obese patients. So registry data that's over 10 years old doesn't have the proportion of obese patients that we see today. Our Transplantation Society of Australia and New Zealand has published guidelines which mirror those of other countries. Most recently, these guidelines have moved away from defining obesity and thresholds in favour of coexisting morbidity, particularly diabetes and cardiovascular disease. We've moved away from defining the risk explicitly, such as previous definitions that the patient should be expected to have an 85% chance of 5-year survival. But in practice, many units have a stated size limit, and that is frequently BMI. Despite its shortcomings as a measure of obesity, and central obesity in particular, it's at least transparent and it's a goal. When I took on the lead at my hospital in 2005, we had a radical plan that we'd increase the BMI limit from 30 to 35. Now we laugh at that because the common limit is more like 37. Our evidence base of metabolic bariatric surgery in renal transplantation has moved from case reports to small series to some larger series, registry studies and systematic reviews. And I think that even this afternoon we've seen that we're often dealing with small numbers of patients and trying to get conclusions from that. But we are moving on. Just this year, Garnham et al. Has reported a collaboration of the American Society of Transplant Surgeons and SAGES, reviewed the literature and produced some, if not guidelines, at least some recommendations about the place of metabolic bariatric surgery in liver and kidney transplantation. CARJA performed a systematic review comparing results of bariatric surgery in end-stage renal failure with a normal cohort, mostly with data after 2006, and also attempted to compare the results of sleeve gastrectomy and Roux gastric bypass. again, considering that sleeve was really only starting about 2006. 5 studies showed that MBS was pretty successful at getting patients listed. Major post-operative complications were greater, as you might expect, and mortality rates, I guess, are unsurprising. Weight loss outcomes between sleeve and gastric bypass were about the same, as were mortality rates. Fernando also published last year a meta-analysis of 28 studies with MBS pre-listing, after listing, in other words, still prior to transplant, at the time of transplant, of which there's 1 study, and then post-transplant, and found in each of these groups there's a mean change of BMI of about the same, about 11 points. They talk about mortality. They combined the mortality of transplant and bariatric surgery and reached a number of 4%, which if you take the transplant as 2%, seems somewhat high. And so when you actually drill down into this, they also include some studies which took patients from the 90s where there was open surgery, where there was no sleeve gastrectomy. And I suspect that this review was a little bit over-inclusive in the series that they included. I'd like to just talk about this simultaneous robotic sleeve gastrectomy and kidney transplant because it's so sexy. It's small, but some numbers, with 11 patients. They got the expected weight loss result, although maybe 50% of excess weight at 12 years is perhaps a little bit modest. And from a transplant point of view, the GFR was exactly the same as what they achieved in smaller patients. This is a really interesting study from Koo et al, and they used US Medicare data, which is fee-for-service claims data, to identify people who had bariatric surgery, and then drilled down to see the ones that had renal transplantation. And they noticed that bariatric surgery was not associated with graft failure or acute rejection, that sleeve gastrectomy, interestingly, had a lower risk of graft failure even than normals. And this case series of 32 patients from McGill University in Canada performed sleeve gastrectomy, achieving, again, what you might expect in terms of weight loss. Of the 32 patients, 27 of them got to listing and 23 of them were actually transplanted. And of those, again, we got the result you might expect. Good survival, 96% graft survival at around about 1 year. So, which operation? We're looking for low risk. There's minimal literature regarding procedures other than sleeve or Roux-Y, and perhaps there's a little bit with gastric banding. And I'd refer you to a poster in our e-posters from my hospital, St Vincent's in Melbourne, with a group of patients who have had various operations, including banding as a prelude to surgery. But it does seem that renal failure patients seem to do better with the sleeve. There are fewer complications. There seems to be better graft survival. This theoretical less alteration in pharmacodynamics is probably not really of much magnitude to worry about. A theoretical risk of less oxalosis, but no data in the long term on reflux or on conversion to Roux-Y. I do need to say a word about the obesity paradox. Data from the early 2000s showed better survival in obese dialysis patients compared to normals. This sparked some debate about whether this was real or an epiphenomenon. The data does seem to have persisted, and it seems on balance that weight loss is not the friend of the haemodialysis patient. PD maybe, transplantation, as I've said, does better with weight loss. But unless you are going to transplant your patient in end-stage renal failure, your weight loss intervention could harm rather than help. Next, if a patient is listed for cadaveric transplantation, the important weight is not now, but when they actually get the transplant, and that may be in 4 or 5 years' time. So you need to offer them durable a durable weight loss. I'd also like to say a few words about organ donors. Again, our guidelines are phrased in a way to maximise acceptance of donors, but the key to this for the live donor is the concern about lifetime risk of diabetes and end-stage renal failure. Commonly, our physicians use risk calculators, but all of these calculators include BMI. And so there's concern even with BMI over 30. Live donors are special people, and treating them is a privilege. One scenario is the couple approaching retirement. Maybe that's me. They've organised their travel plans, bought the caravan, only to find that one of them develops end-stage renal failure and is tied to home. The other partner can achieve their goal if they offer one of their kidneys, but both partners have comorbidities. They are older than our common bariatric or transplant patients. These donors are not patients, they're normal people looking at a mutilating operation. They're screened carefully, and there's a high bar for acceptance, particularly when diabetes or insulin resistance is detected. Effective and durable weight loss is important for candidates offering to donate their kidney. Safe surgery is really only the first part of the story. There's little published data of MBS in live renal donors. Bipolsky matched 23 donors with MBS with another 72 normal donors and 42 MBS controls. They found that compared to the bariatric patients, there was similar weight loss, and the patients with one kidney had a slightly worse lipid profile. Comparing the group to normal-sized donors, they had similar outcomes for post-donation glomerular function. Paoletti from Rome had a systematic review with 7 studies, but only 25 patients overall, all successful in the short term, no complications, but of course this is a long game. So it seems clear that bariatric surgery enables transplantation in candidates who would otherwise miss out. We're beyond the single case report, but really lacking in high-level evidence. Yesterday, Francesco Rubino predicted the future of bariatric surgery will be treating higher risk patients, and this area is one example. We have to be careful in our decision making. Weight loss in non-transplant patients is harmful. Inadequate weight loss that fails to get a patient to listing is harmful. We need to be mindful of the time frame for weight control. We need to be aware of the relative advantages of the different procedures. And there's a next round of questions. What about sleeve revisions? What about reflux? How soon after bariatric surgery can we transplant? Do we have to wait until the weight loss slows down? And what is the place for one anastomosis gastric bypass? That's evidence-free at the moment. So, to you all, welcome to Melbourne. We had a windy start to the week, but I'm told the weather forecast for the weekend is going to be wonderful. Thank you.